I feel like I'm with John Laws.
You feel like you are John Laws?
No, with John Laws.
I'm John Laws in this.
Yeah.
I'm the John Laws in this situation.
Yes, with the golden tonsils.
I don't think anybody has ever described me like that.
You're listening to On the Moans, where we have conversations about hormones, midlife, and the moments that make us wonder, is it just me? I'm Kate. I'm a 48-year-old pharmacist and newly minted perimenopausal oversharer. This is where we talk openly about the changes we aren't prepared for, so we never have to feel alone in them again. I acknowledge the Camaragal people of the Eora Nation, the traditional custodians of the land which I am recording today. I pay my respects to elders past and present, and I extend that respect to all Aboriginal and Torres Strait Islander peoples listening. Always was, always will be Aboriginal land.
Hello friends, welcome to On the Moans. Today we're doing something a little bit different. Instead of talking about menopause or hormones or the latest wellness trend, we're going to step behind the curtain of modern healthcare. My guest is medical oncologist David Thomas. He's spent more than 3 decades caring for people with cancer, and in this conversation I wanted to understand what the job is actually like. What does a typical day look like? How are treatment decisions made? Who are the people sitting around the table in these multidisciplinary meetings we hear so much about? And what keeps someone coming back to a job where they spend day after day supporting people through some of the most challenging moments of their lives? We talk about teamwork, difficult conversations, the importance of good colleagues, and why cancer care is never the work of a single doctor. Most importantly, we talk about the privilege of being invited into people's lives at a time when they are vulnerable, frightened, and searching for hope. So if you've ever wondered what a medical oncologist actually does all day, or why you've had to wait so long in the waiting room, or you've found yourself navigating a healthcare system as a patient, family member, or friend, this conversation is for you. Here's Dr. David Thomas. My first question to you is going to be, you've been a medical oncologist for 35 years, is that right?
No, I don't think so.
How long have you been a medical oncologist for?
20. 20 and a bit.
Oh, because of all of your pre-training. You've been a doctor for 35 years.
I've been a doctor for, 30 years. Yeah.
30 years. But you've been a medical oncologist for 20 years.
Let me just calculate that. Yeah, 95, since 1995. The 90s were good.
So you've been a doctor since 1995?
Yeah, but, as an intern and trainee.
Yeah, so that counts.
Yeah.
But a medical oncologist for 25 years. So my question...
20.
Sorry, I can't help but age you. A medical oncologist for 20 years. So my question to you is... why did you not choose dermatology? Because it seems to me like you've chosen the most emotionally fraught specialty when you could have been telling people just not to eat avocados.
It's true.
Sorry to all my dermatology friends out there. I've completely just oversimplified your amazing knowledge and your amazing career. And I don't mean that, but you understand what I'm trying to say is how on earth do you choose...
Be careful, one of my besties
is a dermatologist.
Yeah.
How is it that you settled into oncology given what I suppose from the outside looks like quite a grim...
Ooh. Well, I had lots of luck. Like all these things, I was doing my basic physician training, and as part of that I did some palliative care. And the palliative care seemed to suit me, and I had lots of very good mentors within that space. Yeah, I did. So I did a fairly extended stint as a palliative care registrar, and as part of that, I had a number of really amazing mentors at the hospital I was training at. And one of them was both a palliative care physician and an oncologist. and was really, really wonderful and pulled me across to oncology. And I thought I was pretty suited to palliative care at the time, but it was nice to be, I guess, trained in oncology because you did some of the palliative care. I think now we're very fortunate because I've got wonderful palliative care colleagues, and they've got amazing expertise. So we don't have to fulfill that role, and you can be an oncologist and be both, an active clinician treating cancer, and you can still utilise some of those skills. So it was, I think it was I was fortunate because I just seemed to run into the right people, and I was fortunate because of just that sequence. Yeah, and when I think back on that, I tend to say this to our trainees, that the palliative care experience, if you can, get as much advice from those specialists, and gather skills in that direction, you're doing well for your oncology career always. Yeah,
because you would think that they would be natural bedfellows.
They are,
Oncology.
And where I work, we're sort of peas in a pod, so we do tend to work really closely together. I think that's the same at most hospitals, and it makes the care of patients as good as it can be.
So take me through a typical day being a medical oncologist. But actually, before we do that, perhaps what I might get you to do is explain the difference between medical oncology and radiation oncology.
So there's broadly, you can, in oncology, you can push people into 3 different groups. God, I hope I don't miss out anybody. But there's surgical oncologists who work in lots of different surgical fields, but, all dealing with cancers. There are radiation oncologists who treat cancer with radiotherapy. So that's really, I guess, you could describe it as most crudely as really strong focused x-rays. And medical oncologists are treating cancers with a combination of different drugs, but some chemotherapies, what are called targeted therapies, immunotherapies, hormonal therapy, but it's generally medications that do the task of either controlling and managing cancers or killing cancers. But everybody is working together as trying our best to work together as a big team. So I'm part of numerous teams within our cancer care centre, and they all involve those groups, but they also involve some specialist radiologists, interventional radiologists, nuclear medicine doctors, pathologists, and then allied health, so specialised nurses. So those teams, and I'm going to miss out people, but also I shouldn't miss out palliative care. Those teams make complex plans for treatment for each type of, each individual patient with an individual cancer. And we try to make our plans as individualised as they can be.
So a term that people might hear is MDT, or multidisciplinary team, and I think that's what you were just describing. Yeah. And I always imagined the MDT meeting to be like the sit room in the West Wing in the White House, when everybody gets together in a darkened room and you sit around a table and it scans up on the projector. Is it anything like that?
Well, for a little while it was. We would gather in...
you can take that to your next MDT too, by the way.
Yeah.
I think...
Yeah, the sit room. Well, for a little while it was. And so, when I was a trainee, we'd push a very big trolley of x-rays into a darkened room, and then we'd gather around light boxes and we'd put up x-rays and CT scans and MRIs.
Times have changed.
and we'd present patients, and it'd be a cluster of surgeons and radiologists and radiation doctors and medical oncologists, and we'd all be gathering together to make plans. So it was both a really good way to do it because it was very personal. So there is nothing like speaking to each other face to face. The downside, of course, is that you do have to get home, and you do have to leave the hospital, and you do have to arrive at ungodly hours when only surgeons and anaesthetists are really inhabiting. I think the main drawback is that most meetings are before and after hospital, and you can't have not everybody's able to be there. We all have at some point in time little kids, and we have to be home, and then, there are some meetings where it's like godforsaken hours where only anaesthetists and surgeons seem to be awake. And so the only really good thing that came out of COVID was that we do most of the meetings now by Zoom or by health teams. And so
You do it by Microsoft Teams.
We do it by Teams, yeah. And the good thing about that is that we just have we can have a pathologist presenting, we can have interventional radiology and x-ray doctors commenting, we can have multiple opinions from all the people attending, and we'll just get a much bigger array of people. I think people are much more enabled to have an opinion in that setting.
So you present your own patient. How do you get on how do you, as a patient, get into this sit room of specialists?
Yeah, it's essentially you act as the advocate for your patients. So you take patients to meetings to present and ask questions, and you might ask questions about the pathology or the radiology and just the options for management. But the idea is that you're getting an opinion from the team regarding, best management, and it may mean incorporating a surgical approach or interventional radiology or radiation oncology approach. And so you'll bring people into the care of your patient, but you're acting as the advocate for your patient, and ideally giving them the best care.
Amazing exposure to a whole bunch of people and their expertise that they may not have had. And typically you see somebody in your clinic and you think it would be good to get the MDT.
Yeah, I think all of us would. I think it's probably it would be nearly the majority of our patients that we'd present in those meetings. And so, those meetings, sometimes they can be quite long, but they're all very good because you have the opportunity to actually help your colleagues by contributing your opinion. You also, you learn because you'll hear the thoughts of your colleagues. So it's like having a further opinion. I think it encourages your own confidence in the actions that you're taking, and you're able to also pass that on to your patients. So, look, I've discussed this with my team, members. I think, I see patients within the clinic, but they may not be aware that there's a lot of discussion in the background, that there's time spent in meetings talking about their scans and talking about their pathology.
And so how many MDTs would you attend each week?
I think I attend approximately 4.
4 multidisciplinary team meetings in a subspecialty of your specialty.
In a sort of super specialisation. So it might be there's always something on Monday night, and when there's not, it's actually kind of a nice day because you've finished on time.
What's on a Monday night?
And Monday nights often we have, alternating weeks where it's upper gastrointestinal cancers. So that's things like pancreas cancer and esophageal cancer. And it's a really well-attended meeting. It's really, really valuable for me. And, I really value the opinions that are given there. And then Tuesday's off, again alternating, but it's colorectal cancer, and so again it's for quite a particular situation. But there's lots of discussions about integrating intensive chemotherapy and radiotherapy. And then Wednesday again is alternating between melanoma therapy and again gastrointestinal cancers, but particularly liver cancers. And then Thursday alternates as well, and that's about brain cancers. And that, again, is a really terrific meeting. It's really well attended. It's got a sort of cast of many surgeons. And we have a great combination of very really capable, really terrific surgeons and terrific radiation oncologists. So, and we're devising plans for people who are really in the toughest, moments in their life. So Friday is, again, on alternating weeks, but it's a neuroendocrine tumour MDT, and it's really very specialised. It's is a meeting that I really enjoy because it incorporates a number of people that are from different teams, from medical oncology, surgery, interventional radiology, nuclear medicine. We've been working together for a long time, and I think we all appreciate that it's an area that we make a difference. So, yeah, it sounds like it's a busy week.
It sounds like it's a hugely busy week, and I guess I'm sitting here wondering how you get anything else done. What is a typical... So choose your favourite day of the week or your least favourite day of the week and explain to us how that day is run, because I'm guessing on top of all of... So you've only spoken to us about multidisciplinary team meetings, but you'll have inpatients, you'll have clinics.
So I think it's a mixture. Every day's got the good and the bad. So I'm part of a big team of oncologists. So, and we cover 2 hospitals, but between us, and at any one time there's 3 of us covering the wards and another hospital and somebody being on call, and then there's people covering the private hospital. So there's always you're always doing some cover for inpatients, and we all do a mixture of clinics through the week. So that's outpatient clinics where you see a whole bunch of people who are living with their cancer. They might be having treatment with a cure in mind. They might be having treatment with palliation in mind. And you are seeing each person. They may have vastly different problems. So some people will come in and it will be really simple, and then other people will come to see you and it'll be incredibly complex. And
these are people coming in from home?
Yeah, from home with family members. We're really dependent on our advanced trainees who see patients with us. And so there's some teaching that goes with that. There's a lot of discussions about what's to be done now, what's to be done next, where a person is in their sort of journey. I think my colleagues would share very similar experiences. We all look after different cancers, as you could hear, and so we have focuses on different cancers. And when I was just a younger doctor, we used to look after all the different types of cancers and even some of the blood cancers. It was partly because the knowledge of cancer was not as great and therapy wasn't as good. But with knowledge increasing, therapy improving, becoming more complex. Between all of us, we focus on different, I guess, organ systems. And so we have different associations with particular radiation doctors and surgeons who look after those systems.
So you're a specialist oncologist, medical oncologist, but within that specialisation, you are super specialised on...
Well, you focus on, with me, it's focus on gastrointestinal cancers. That probably makes up most of what I do, but also I look after this particular, I guess, reasonably uncommon cancer called neuroendocrine tumours. I look after nervous system tumours, and I look after patients with melanomas. So there's still a breadth, and I think all of us have that kind of breadth to our practice.
But if I have a breast cancer, I don't come and see you. No. And you know, because we're on call at different times, we'll see patients who have cancers that, you know, we may not be as comfortable with looking after. So we'll ask our colleagues who do look after those cancers to take them over.
Yeah.
So you
absolutely.
might be called in the middle of the night for someone with a breast cancer, but then the next day you're handing that back over to the breast cancer specialist.
Yeah, absolutely.
What is a typical day looking like for you? Or give us a typical Friday.
I'm going to go with Friday because it's got some good stuff and some bad stuff. Well, not bad stuff, but there's some hard things in it. So the good stuff is I usually get up and I try to do some sort of exercise. Mm-hmm. That's always good.
That's important for your mental health?
It's good for my mental health. And I then head in, and when I go in, I usually get a coffee, and I usually almost always bump into nurses from our ward, the oncology ward, so I say hi.
Oh, wait a second. Wasn't there a meeting on Friday? I can't remember which one.
That starts at 8. So it's actually at a kind of almost normal time.
So this is all happening before 8 before your day officially starts at 8.
And then I usually get cakes and donuts and stuff for the clinic because I feel like I owe it to everyone because my clinic's a little bit chaotic. And
that's for the staff.
That's for everybody.
Oh, for the patients as well?
I don't know. I think they might take a few things.
Oh, okay.
Yeah. But it's very, for everybody with cardiovascular disease, not really good.
So sorry, we're only up to 8 a.m. and you've bought coffee and run into some nurses?
Yeah, and so then depending on the day, there might be a meeting at 8, which would be an MDT, and that's actually is really good. It's just that it's usually sort of running into other things. Again, for myself and my colleagues, if we're on call and covering the wards, then we have to sort of think, oh gosh, how are we going to go up to the ward? We've got wonderful physician trainees who run the wards with our junior medical staff. These are the interns and residents and registrars, and they're amazing. And we've got a ward that's also incredible, very just an amazingly experienced nursing staff and allied health. So we've got a ward that just
you feel comfortable that if you're on for that ward and you're not physically on that ward, that they're making good decisions, and if they need to run a decision past you, then they will know. Yeah.
And I think we've just got such experienced nursing staff that, they know when problems are brewing, when, issues are occurring with patients. And I think it just makes the care really, really, really amazing.
And why would you be an inpatient?
So you might be an inpatient for a few reasons, but it's you can broadly say it's patients coming in because of complications of their cancer. So they've got a cancer causing
pain or
so symptomatic concerns, or it may be actually creating physical, mechanical problems, blockages, and or creating infections as a complication of that. There's patients who, those patients really benefit from the input from palliative care. So palliative care have a big presence on the ward. The other group are patients who are on treatment and they're getting complications from that treatment. And I think we see that that's become more complex because we give a particular type of treatment called immunotherapy, which has made our care, again, vastly better for a lot of different types of cancer, but it has created also its own complications, and they are sometimes really, they're difficult to manage, but they also require, and I think this is a good thing, they often require the input from our other colleagues from other subspecialties, so gastroenterology, renal medicine, cardiology, and sort of ties people together, which is, ties there, or you get a greater degree of cooperation within the hospital, which I think is always good. I think you can broadly put people into those two groups.
Categories.
Problems from the cancer, problems from treatment, and people can, a lot of people have very extended stays in hospital. I just always marvel at what we're able to do. I think that the ability to remedy complex problems is amazing.
Magic.
There's also people who are unable to recover, and again, it's where we've got that backup of palliative care to both manage symptoms, but it's also to manage end-of-life care as well. And I think where we've got that cooperation, we've just got, really, again, very talented nursing and medical staff. You can make a big difference to people.
Huge difference.
And to their families. I mean, that's the other thing.
So far we're up to 8 a.m.
Oh, yeah. So 8.
Oh, no, you've done the meeting by now, so maybe now it's 9:30.
And so then the day does get a little crazy because the clinics are...
So you go from wherever it is you attend the meeting to now the
so
space
we're in the cancer care centre, and there's an outpatients clinic, and at the same time as I run my clinic, I've got a number of colleagues running their clinics as well, and that's great because you kind of, again, there's a little bit of camaraderie, and we all you can talk to those colleagues along the way.
How many people are you seeing in this clinic typically?
Probably at least 20 patients.
This is just the morning?
And this is a bit of the morning stretching into the afternoon.
Okay.
So, and I'm given to talking a lot. So unfortunately, I'm just not very good at remaining on time. But I also look after particular tumour streams where, it can be complex, and I think we have long conversations, and
they don't sound like conversations that can be done in 10 minutes.
No. And there's often tasks that you have to do that, require much more time outside of the actual face-to-face discussion. So we have, again, I just emphasise we've got amazing allied health. So that, we've got people from dietetics who are amazing, who for our gastrointestinal patients, keep people on the straight and narrow, make everybody, keep everybody's spirits up. We've got people from clinical psychology looking after patients and their families. We've got nurse specialists who are just...
Nurse practitioners?
Nurse practitioners, but, we've got essentially amazing nurses looking after... Again, it's outside of that 15 or 20 minutes of discussion.
So if I'm a patient in your waiting room and I come to your outpatient clinic, so I'm sitting in my chair, I've checked in with reception, so they know I'm there. I'm sitting in the waiting room. What's going to happen to me? You're going to come and say my name, or do you have help? Will I see your registrar?
Well, some people will see me. Most people will see me, but a fair proportion will see my registrar, who's, again, amazing. And they'll, devise a plan, and then we'll discuss that plan and see if there's any, anything else that's needed to be done, and then it's a case of just organising. What's going to happen next? Is it about treatment? Is it just about symptomatic care? Do we have to link the patient up with community teams? What else is going to actually
Or I might see the dietitian.
Yeah, absolutely. There's, I've missed out speech pathology.
Yeah, OT, whatever it is.
Yeah, absolutely.
Physio, whatever it is.
Whatever's required.
You might write a prescription for something.
Quite a few prescriptions. So it's keeping people moving on that journey, whether it's about treatment that's being given following surgery with the intention of reducing risk of recurrence. So if it's treatment that's being given before surgery, with the idea of improving the chances of cure, or whether it's treatment that's been given with a palliation in mind, a palliative intent to see if we can give people more time, a better quality of life. All of those, they're sort of general streams of care. But to do that, it requires lots of people, and a lot of thought, and not just from myself, but just from multiple individuals, but working together as a team. So
I think people probably have a vague understanding of what it is to sit in a waiting room and then see the doctor, because most people have seen a GP.
Yeah.
So they're familiar with that sort of process. But I think what people don't understand is that, none of what you've just described to me sounds like a conversation you could have in 15 minutes for a start. But then also the amount of follow-up that happens once that person's left. So your 20-person clinic isn't 20 lots of 15-minute consults. It's actually a huge amount of background work is what I'm hearing you say.
I think so. I think the better to do it well, I think it does require requires a lot of people. Yeah, it's just impossible to do it as an individual, and we're just I think we're fortunate where I work. I'm fortunate, but I know that sort of team approach is pretty much as standard, and I think we're very proud of it. Again, where I work, that we have some really good, really terrific teams.
So now are we up to?
Oh, we're up to.
Now we're up to lunch, but it sounds like we're late.
So I have. Yes, I have.
Do you ever have lunch? Do you ever get lunch?
I have a yogurt and muesli, which sits on my table until about 3:00.
Oh, that sounds
really
delightful,
nice.
Warm.
And I think I might grab a second coffee at about 3:30. But normally afterwards, it's a case of seeing, it'll be catching up with consults, maybe seeing some patients again at the private hospital. It'll be trying to sort of finish the
admin tasks.
Finish the week. It's I think it can be sometimes the best part of the week, because I really like going to the ward, and I like I think we have just wonderful young doctors looking after the patients, so I really enjoy just seeing the patients with them. I'm very slow, so they probably don't enjoy that at all. But that's a really good positive part of the day.
I imagine if you're a patient, thankfully I've never been an oncology patient, but I imagine if you are an oncology patient and you're lying in an inpatient bed on the oncology ward, and your oncologist comes and they spend some time talking with you, I imagine that is very precious. I can't imagine being able to do that round in any kind of speedy way.
No, and I think, there's definitely efficiency, and all of us have, you just find your speed and your personality sort of determines how you will, go about how you'll talk to people. But I think all of us, try to maximise that time. It's that communication makes it much easier when
we know
when there are hard times. So if there are hard discussions, hard conversations to have, then I think if you've spent time before and you have trust, then I think that makes those conversations easier. Never, I don't think easy, but it does definitely make the conversation more
genuine.
Yeah, I think that's a good way to describe it.
I was going to say that all relationships are built on trust. Every one, I guess, even the incidental ones you have with your barista, they're all built on the fact that they're going to trust them to make you a nice coffee. But if you are really facing your mortality and you're looking at treatment options, then the trust relationship you have with your treating doctor is absolutely paramount. And the only way to build that up is with time and genuine time. And the only way, there's no shortcut around that, I guess, is what I'm trying to get at.
No,
No.
it's pretty straightforward.
So what time of the day are we up to now?
Oh, we're getting close to clock off time.
Quitting time.
Quitting time. Yeah, quitting time.
What time is quitting time?
Quitting time? I know I can't lie to you, but it's usually about 6.
Is it? I can see your nose getting longer. What time is quitting? What time is quitting time?
About 6.
What time is it really?
No, I think it is generally about 6. I can average that out over many months.
I can average that out, and I can tell all the people listening that his average quitting time on a Friday is much more like 6:30, and last Friday was 7:30.
Really?
So we've gone. And you've started your first. So forgetting when you got up to go for your run, you arrived at work before 8 so that you could be in the meeting at 8, and now you're leaving at 7:30. That's a long day.
It is a long, it is long. That's why you go for a run beforehand.
What time are you going for a run?
In the wee hours. I think it's probably the hours that, if I go out and you do see other people, they're usually probably surgeons and anaesthetists actually. But I would say that's not, that's, just a day shared by my colleagues, very much, by my colleagues as well. So
how do
when we round at different times, we wave at each other and go, yes,
you're here,
you're here too.
How do you, if you're doing that 5 days a week, I know that most of your multidisciplinary team meetings start at 7 in the morning.
Yeah.
The morning ones start at 7, except for this lazy one on a Friday that starts at 8.
Yeah.
And so if you're up and ready to be at work by 7 and then not coming home until 7, then that's 5 12-hour days. How do you maintain that? Because now you've got 5 12-hour days of seeing people who are sick, on seeing family members who are unhappy, rightfully grieving.
Yeah, absolutely. I think the way it is hard to maintain, obviously. It's because it doesn't matter what job you do, if you have long days, and that, it's more and more frequent. I think, that all of us are working longer days, that there's a bit of endurance, and it's definitely not completely healthy.
Well, it doesn't sound like much of a work-life balance.
So it makes the weekend very important.
And short.
Yeah, a little bit short sometimes. I think what it means is it makes relationships with colleagues really important. So those, and when I say colleagues, I mean my doctor colleagues, but also from nursing and allied health. I think having those good and, being able to have a bit of a laugh, and I think most of my colleagues that bring some, humour to their work. So having a good team, having I think being able to work as part of these multidisciplinary teams makes a massive difference. I think being unfortunately, running in the middle of the morning. Yeah, it's 4:30. 4:30 is the best time.
Lonely. Very lonely at that time. Very dark.
Yeah, I think everybody is sort of probably trying their best to do something similar. And I know our kids, as they've said, are big munchkins now, but I know my colleagues have little munchkins, which require so much, there's so much time that, that they take. And
it really is.
I think they're really amazing how they're able to do that. We're coming into a different sort of stage of life, but, doing some of the training that they've done, the PhDs that they've done, having children, little kids, and still being, great clinicians is really amazing.
Yeah.
So there's different challenges and different stages of life. I feel like this is a pretty good one, this stage.
Yeah. What would you say as a takeaway to anybody thinking about getting into medicine, or perhaps the people who are in medicine who are thinking about getting into oncology? Would you say, run away? Or would you say, go for it?
Yeah, well, I always, we have trainees with us, and again, more and more of the trainees are just really impressive young people, and I would generally say, look, come on board. It's
because you're not selling it, to be honest. 4:30 in the morning run.
No.
Meeting every morning at 7 a.m. Stay at work and deal with people who are dying of cancer all day, and then come home at 7:30.
I think
my tip for them is.
No, I do. I mean, I'd say, definitely come on board. I think, we've got some colleagues who've done dual training. I think that's been a really good way to, I know.
I've just robbed for people because it's a podcast, so you can't see me, but I've just had a massive of like, why would you do it to yourself? Dual training in what?
I know, but
oncology in what?
Nuclear medicine, and I think some other bits and pieces. Yeah.
Wow.
So, but the good thing about medicine is that there are there's so many different parts to it, and so many different parts that can suit a different personalities, and you have to, in a way, you sort of have to pick what's going to be, you almost have to be sort of fortunate to make sure that you're picking the right one for you, for your personality type. I was very fortunate, I'd say. I had thoughts of doing other specialties, and I just really had great people. Yeah, good, very, very good mentors. I think that made such a big difference. So I think all of us in oncology would think of it as being a very fine thing to do, that you can do, it's a good vocation.
Not depressing?
I don't think so. I see mostly the best in people. Yeah. In terrible situations, you see the sort of finest.
Gosh, are you emotional? You're a cute man. This is why he's late, everybody, in his waiting room. So just be patient with him.
I'm going to have a drink. No, not of water. Sorry.
We can cut that out.
You can cut that out. No, I see the, people, whether it's the patients themselves or their families, being just the most amazing behaviour. Yeah,
love,
yeah,
support, care.
love. I think.
Yeah, love. Yeah. Dr. David Thomas, you're a delightful guest. Will you come back on my podcast? Because I have questions about, well, I want to know the difference between chemotherapy and immunotherapy and targeted therapy. And I think lots of people want to know that because I feel like chemotherapy is a word that is sort of maybe misunderstood and is grouping a lot of different things together. And also I think people have this idea that chemotherapy is that bright red one. Is that doxorubicin? And it's not all like that anymore.
It's not cortical.
Not anymore. As a pharmacist, there seems to be a new monoclonal antibody that someone has just randomly put a bunch of letters in front of and then MAB at the end and then called that a drug name.
Within our department, we have a big range of ages, and I am now at the geriatric end.
You're getting old.
I'm getting old and grey. And I share that with a few of my colleagues, and we can look back at the days when there were very few things that we could do. And
they were really toxic.
Yeah, and not very effective. But also the really good thing that we can look at is the way in which new treatments have developed and come on board, and the differences they've made. And that's really wonderful. Being able to look over that expanse of time is actually, whilst it's worrying because it is an expanse, it's also gives you a nice perspective, mainly that things have improved. I don't think any aspect of it has gotten worse.
Has deproved, as my friend would say.
And so, the models for care are better. When I was a younger doctor, they didn't have MDTs. In fact, people were thinking, they don't actually, there's no evidence to show that they have make a benefit. You don't have to get together and collaborate with your colleagues.
Isn't that a crazy way of thinking?
It is really crazy. So the understanding of cancer, the understanding of the body, the understanding of the immune system's all improved. The number of agents and the way in which they can make them is just astonishing. The complexity is increased. It's made it harder to get your head around, but at the same time, it's all, again, it's positives. So, when there was just one thing that would change in a few years, and now pretty much every year it seems to bring an advance. It's just, it's quite marvellous.
It's not quite the death sentence that it was. I know that a lot of cancer is hard to treat and ultimately terminal, but
there are still, still cancers that have that, and we want to see, changes. Perhaps, some of those cancers where it is difficult, there's still advances, but the increments are smaller, but we're still seeing improvements. So all of that makes a big
exciting
difference.
Medicine.
Yeah, and my namesake, Dr.
David Thomas,
Professor David Thomas, he is, I guess, organisation OMACO or CASP, at the forefront of what we want, which is
genetic testing,
a breakdown of the character of the cancer, and just seeing whether there are personalised specific options for treatment. So that's one aspect I can think of. That's a great change in what we do, but it's across the board.
So will you come back on the Moans and talk to us about treatment and how it's changed and the life-saving chemicals that we're able to give people and genetic testing? We'd love to have you.
I shall come back, and I will bring my dog.
Don't bring your dog.
I'll bring my dog. He's awesome.
The little dog is just lying on the couch, just on the pillow, being very cute.
Yeah.
So thanks for coming on the Moans.
Yeah, thanks for, I hope that was good.
That was wonderful. It was so informative. Thank you.
No worries.
Bye.
Bye.
Many thanks to David for joining me in this podcast. One of the things that struck with me most from this conversation is that while we often think cancer is about scans, pathology results, and treatment protocols, what really came through was the importance of people. The nurses, pharmacists, surgeons, radiation oncologists, nuclear medicine, palliative care teams, allied health staff, and administrative teams who work together behind the scenes. The colleagues who challenge each other, support each other, and ultimately help deliver amazing patient-centered, holistic care for better outcomes. And perhaps most of all, the patients and families themselves. David spoke about the privilege of being welcomed into people's lives during some of their darkest moments, but also witnessing extraordinary resilience, generosity, and love. If you've enjoyed this episode, please subscribe and leave a review and share it with someone who might find it interesting. And if you'd like to hear more conversations that pull back the curtain on how healthcare really works, let me know what area of healthcare you'd be interested in. As always, you can find me on TikTok and Instagram at PrescribeOrPass, and on YouTube, On the Moans. Until next time we get on the moans, take care of yourselves and each other. Bye-bye.